Okay, so I will post this up. Everyone see that I published the Fluid and Electrolytes lecture on the Clin Pharm course. That's up now. I apologize. I just now got access to the course myself. So you can download that and check it out. About the research projects, I'm about halfway through everyone's reference list so far. You don't have to have a grade on that to continue on with your work. So keep going with that. You guys see that for this week, you'll have that quiz that'll be due at the end just on a stats review. I already saw by Monday, 8 people already done with it. So I'm like, slow down. You got time. It's a marathon, not a race, right? But yeah, so you can work through that stuff. I'll have the next following week's material up probably about Wednesday or so. Get that ready for you guys. And then, yeah, that's pretty much it. So the references, I think most people are doing a pretty good job with it. Again, I don't care if you copy and paste things. I do the same thing when I'm doing my reference list, right? But you need to go through and actually make sure that it's meeting the formatting that you're looking for. So if I see stuff where it's like it's an Arial font here and then the Times New Roman and then wingdings here, like that looks sloppy, right? You want to make sure it's all the same type size. You want to make sure it's all the same font. Make sure the formatting's correct. So if you're doing periods after the page numbers, do that consistently throughout, right? That helps to make your product look more professional, look more serious when you submit the final thing. Some of you will have to redo it, but it's just based off the fact that it's not meeting really the quality standards. Again, that does not hurt your grade. Just redo it, resubmit it, and then we'll go from there. Okay. And like I said, I'll get the rest of those done probably today. And so if you have any questions, just let me know. Any other questions on the research so far? Everyone looks like they're pulling decent references, not having too many problems finding in-date stuff, and then just continue on. I think the next thing will be the the article review, which again you'll be doing anyway when you're looking through these articles. There's just a more formalized sort of process there. So I'll get that posted up pretty soon. Anyway, so what are we talking about today? Do you guys know? I'm not sure either. Okay, well, let's talk about fluids and electrolytes. How about that? That'll be something we can talk about. Fluids, we have a lot of them. Mucus, we have blood, I'm just kidding. No, we're talking about specifically about IV fluids and how we're going to be administering them to our patients. Again, we could have an entire course talking about, PO fluids and nutrition and all the electrolyte stuff. I can only have 2 hours to really fit this in. Ashley could probably give a better talk than I could on this stuff, so maybe you can interject if you have any comments or anything in terms of your clinical experience. Feel free, or if anyone does for that matter, feel free to jump in. This is just kind of my perspective, kind of what I see, and some things I think that are important that you want to know when you're going to be writing these fluid orders for your patients there. Anyway, right, so we're talking about fluid replacement and maintenance. We'll talk about the types of fluids we're going to be using. We'll talk about rates of fluids. Some of you are already familiar with this because we've talked about it before. You've had to write orders like this on your prescription assignments. So again, some of this will be a review. That's totally fine, but we'll go into more details on kind of the nitty-gritty details of it. We'll talk about our rationale for why we select one type of fluid versus another, like why in surgery you see mostly lactated ringers being used versus everywhere else it's mostly NS. Like, why is that? We'll find out, right? We'll talk about that. And then some pitfalls you want to be careful of when dealing with hospitalized patients. Yeah. Okay, I don't know if this video is going to work here, but this is how you don't want to manage fluids. Let's see if this works. I hope it's not too loud. You guys hear that?
Don't worry, sir. After this transfusion, you'll be just fine.
I've only seen heroism like that one other time. Maybe you know the pilot, Leland Buzz Harvey.
Has anyone seen Hot Shots before?
I've been carrying the secret
Before your time, it's amazing.
20 years. I never spoke up. I wanted him to fail. I wanted to be number one. I was in love with your mother.
It's not important now, sir. Please, save your strength for the court martial.
Well, Topper, you had me pegged right. I was throwing a big game. I really thought we needed that. Well, I realized that American flames will always be superior as long as...
So again, that's not how we manage our fluids in patients, obviously. It's a little bit more formalized than that. Obviously, you don't do direct blood-to-blood transfers. That would be very inappropriate, very dangerous for a number of reasons. But anyway, so let's talk about the type of fluids we're going to be using for our patients here. Let's start off with the case. Briefly, we'll kind of introduce this with a case, go through some of the details, and then kind of get back to a few more cases towards the end here. And you may think, oh, wow, only 31 slides. This will go by quick. Sorry, probably won't, but that's okay. We'll get through it, right? So anyway, let's say we have a 34-year-old, 80-kilogram male. He's presenting to the ER. He's at fever, vomiting, diarrhea, due to gastroenteritis. He appears dehydrated. How do patients appear dehydrated? Skin turgors down. What else? Mucous membranes look dry. Eyes might be a little bit more sunken in. You know, like all those little things you're going to notice. Like you can tell when someone's dehydrated, right? Probably like some of your classmates after like a Saturday night or something. Like you may appear dehydrated, right? Drink lots of water, people. Anyway, so he is unable to tolerate oral fluid replacement, which would obviously always be ideal. Why do we prefer oral versus IV fluid replacement? I don't have to stick a patient, right? So again, anytime you're introducing a needle into a patient, like there's a possible risk for infection. You can blow a vein. There's lots of problems. Some people have a hard time getting IV access in the first place, especially kids. So if you can use oral, we always prefer going oral whenever possible, right? That goes for medications. It goes for lots of different things. Okay. Let's look at them. Let's say you have a heart rate of 120, BP 95 over 68, and his temperature is 39 degrees Celsius. What do you think so far about the vital signs? Clinically, he appeared dehydrated. Why is that? He's a little tacky, and what else? A little hypotensive, right? We don't know what his baseline is, but we can presume that, you know, he's a 34-year-old guy, hopefully otherwise healthy. So again, he would appear slightly dehydrated, mainly due to the fact that he's tachycardic and he's hypotensive, right? So again, what type of shock could that patient eventually progress into? Right, hypovolemic shock, right? Because he's hypovolemic. So let's give him more fluids. Let's try to replete that, try to get the hose filled back up with water, so to speak. And that way he can keep his pressure up. He can pump that around. The heart doesn't have to work as hard, right? So we can get that cardiac output back down and get the blood pressure back up. So in this case, what kind of fluids do you want to use? Normal saline? Why normal saline? Is normal to use normal saline? There's a rationale. That's the right answer, but you always want to know why that's the right answer, right? You want to have a rationale for what you're doing there. Could I use something like LR? Probably, right? We'll look at the practical considerations of doing that in a little bit. Half NS with D5W. We have a lot of options that are out there, right? Not only that, these are crystalloids or colloid solutions. They're crystalloids, right? What makes them a crystalloid? They have salt in them, right? So not just sodium chloride salt, but any sort of salt. Potassium, magnesium, calcium, any of those things are salts. What would make it something a colloid? Yeah, albumin is a very good example of a colloid. Anything else you guys heard about? Things like head of starch and different types of starch products, but those are called colloids. They're usually protein-based in a lot of cases. Albumin is one of the more common ones. We actually had a patient yesterday who were doing a therapeutic plasma exchange, like an apheresis sort of process, and so we were giving them 2 liters of plasma back after the apheresis, and then also 4 liters of albumin back. We'll talk about the concentrations and all of that, but basically giving a ton of colloid to that patient versus using just pure crystalloids. Anyway, and how much do you want to give this patient? A little bit? A lot? A lot? You start off with a lot. Now, the thing with fluids as well is you always want to consider, can I always give more? Yes. Is it easy to take it back? Not always, right? So you have to consider, like, well, how at risk is my patient for fluid overload? How does fluid overload usually present? Edema, what else? What's a nice big open space that fluid likes to accumulate? The lungs, right? So again, you worry about, especially with patients who have poor cardiovascular function, you worry about pulmonary edema developing there. And in fact, that is a big deal, especially for a CHF patient or patients with, like, say, renal failure. If you over fluid replete them, you're going to find that fluid's going to accumulate in the lungs. They sound nice and junky. You're going to be pulling up a bunch of pink frothy sputum. It's no good, right? Because that impairs the oxygen exchange, and that's no good. So you have to be careful depending on the type of patient you're dealing with. But let's get into the details of it to see what we're going to be using here. So looking at this, total body water should be about 50 to 60% of your body weight, right? Now, that will depend on different disease states and whatnot, but just on an average person, you're going to find about 50 to 60%. Now, who typically has higher body water percentage, would you say males versus females? Yeah, usually on pound per pound basis, generally males will. Just mainly females have a little bit more adipose tissue, so that is taking up some of that water space, so to speak. Again, that is a very generalized sort of assumption there, but that's one we use for some of our calculations when trying to determine, like, what's the total body water that a person has. We'll kind of go under those assumptions there. Just know people will violate that from time to time. Breaking it down, you're going to have our intracellular fluid, right? And I remember the memory aid I used to talk about our cells. Salt wrapped banana, right? So this always comes back to haunt you guys, right? So you can't ever forget stuff I taught you way back in the summertime. 1 year ago, actually, I was teaching this kind of stuff to you guys. That's all coming back. So anyway, right, our intracellular fluid is about 2/3 of that total body water, right? So you have a lot of water within the cells. That's mainly potassium is going to be the main positive ion that's making that up. And in fact, if you look at sodium and potassium content with total body amount, you're going to find that it's actually pretty equal. And when you're looking at replacement amounts, say for instance I was trying to dose parental nutrition for a patient like I was just doing yesterday, typically the amounts of potassium and sodium you need in general is pretty equal for the most part. Maybe 1 to 2 milliequivalents per kilogram of both sodium and potassium generally can replace for most patients. We'll have some of this can be transcellular fluid, and then we'll have our extracellular fluid, which is another big component we're looking at, and that's mostly going to be sodium, right? Now what's a normal serum sodium level? 135 to 145 is generally considered to be a normal serum sodium. What's a normal serum potassium? Usually 3.5 to 5, right? You might find some labs will go a little bit above or below that, but generally 3.5 to 5 is pretty consistent. Now, I just said we have a lot more potassium in the cell, so if you were to maybe actually check an intracellular concentration of potassium, you'd actually find it'd be pretty similar, probably be close to 135 to 145 if you had to guess. But we know that most of that is being held within the cells, mainly due to the actions of what pump? Sodium potassium pump, right? So because of that, we keep most of our potassium in the cells, and so that's why you see that the actual plasma level of potassium tends to be 3.5 to 5, which is good, because if it was say 6 or 7, what kind of problem would you develop? Arrhythmias, right? You could die from that. We see that frequently with patients with renal dysfunction who can't process potassium well. They tend to hold on to too much of it. That's where you see those potassiums of 7, 8, 9, and those patients can be really a big risk for those ventricular dysrhythmias. Anyway, though, so again, the extracellular fluid is going to be kind of similar to the intravascular space, right? But we'll see that when we're measuring that, that's what we're measuring directly, right? When you take blood, you're measuring that intravascular space there, and again, it should be pretty similar to what's in the interstitial space, right? So that's kind of how that breakdown of the extracellular body water goes there. I'm sorry, I wasn't using my laser pointer, so you can see where I'm pointing a little bit easier there. But and again, when we are giving IV fluids, where are we putting it? Generally into the intravascular space, and then it has to be able to go from there, right? So again, it's going to go from the intravascular space, it'll partition out into the interstitial space, which can then get into the intracellular fluid, right? So again, it kind of goes one place to the next. And again, it's important to know, well, how will I shift that fluid based on what property of the fluid that I give? It goes back to osmolarity, right? So again, if I give something that is the same osmolarity as in my blood, what do you consider that to be? Isotonic. If I get something that's a higher osmolarity, it is hypertonic, and then if it's less than hypotonic, right? And so remember, we can cause big fluid shifts based on if we're giving hyper, hypo, or isotonic fluids. And we'll talk about that more in detail here. So looking at our fluids, we're talking about osmotic pressure, right? So again, that's talking about how we're shifting those fluids around based off the pressure that the fluids we're giving are exerting, right? And so again, we're going to find that in the extracellular space, the majority of the osmotic pressure is being held up by sodium. Now again, if you look here, normal serum osmolality tends to be somewhere around 275 to 295. Now we said sodium is usually measured at 135 to 145. So what is making up the rest of this? What goes with sodium? Chloride, right? So again, when you measure chloride levels in the patient, what is a normal level? Yeah, usually like in the low 110, somewhere around there, right? So again, you get a little bit fuzzier kind of range on that than you would for your sodium. But so a lot of that is being made up because again, if you look at them, they're monovalent, so they each kind of donate, one positive charge to this total osmolality here. Again, you'll hear me talk about osmolarity and osmolality. I know they're not the same, but again, I'm not smart enough to keep the difference in mind very well. I don't know if you are. If you are, fantastic. You can correct me every time if you like, but it doesn't really matter clinically. But point being is there's other things like serum proteins, right? What's a big protein in the blood that's going to contribute to this as well? Albumin's a big one. There's other things like alpha-1 acid glycoprotein. There's lots of little things that try to contribute to that, but the main thing is our sodium and our chloride are providing that. Now, are there any substances that I could give that could increase that? Sugar can do it, right? So if you were to measure the osmolality of a patient, say it was hyperglycemic, they would have a high osmolality. What if I were to say put alcohol into the blood, right? So you go out for Friday night, have a few drinks at the bar, your osmolality will also be increased because that blood provides serum osmoles, and actually that's something we look for when we're dealing with patients who maybe show up drunk to the ER, right? And we're worried about they might have ingested, say, a toxic substance that could affect that. Those are labs we might be looking at, right? You guys have heard of an osmolar gap before? That's something sometimes we'll actually measure to determine if there's something else floating around in the blood that's contributing to that. But let's say this is normal here, right? As I mentioned, potassium mainly responsible for that intracellular space. Now, looking at these are very common fluids you're going to be running into, say in the hospital setting or in the clinic setting you may be administering here. Now, D5W just means what? It's 5% dextrose in water. What does 5% mean? So it basically means 5 grams per 100 mLs, but if you remember, we can convert that percentage over into milligrams per ml. And that's important when you're talking about things like, well, how much dextrose am I giving my patient? How many calories am I giving them? And we'll talk about that a little bit later in just a second here. The one thing you want to know, though, is when we're giving dextrose 5 grams per deciliter, right, or 100 mLs, we see here that the osmolality of it is actually pretty close to what our serum osmolality actually is. But when you're looking at it, there's no sodium, there's no chloride, which makes sense. It's just dextrose in water, but it tends to be hypotonic. And the question is, well, why is that hypotonic overall? Why do you think that is? Yeah, the glucose gets utilized, right? So our body either will shuttle it into the cells, it'll break it down, it goes to the liver. It does not stay in the intravascular space for very long, right? Because again, glucose is our main energy source, is what we're going to be using it for. So it's not going to be sticking around for very long in the intravascular space. So when we're giving this, we consider this to be free water, right? Because that dextrose is not going to stick around. So by giving free water, you're going to find that you're shifting where that fluid's going to be going to, right? Because it doesn't exert really any oncotic pressure for very long, or osmotic pressure, I should say. And so you're going to find that some of it will stay in the extracellular space, some of that will be in the intravascular space, some of that will be in the interstitium, but a lot of it ends up in the intracellular fluid, right, within the cells. So what do you think that could do potentially to those cells? Because remember, the solute content of the cells themselves is much higher. There's a lot of potassium there, so that fluid's going to want to rush into those cells, and thus the cells will then what? They can swell and then potentially lyse, right? That's obviously a big concern we have there. You can see that in cases where, say, for instance, you were to give too much free water to a patient, and you're going to find that the CNS, right, we have that blood-brain barrier that kind of slowly will equilibrate with the blood. You can actually find that fluid will run into the brain, and then what happens there? You have cerebral edema, you have cerebral swelling, and where does brain want to go when it's swollen? Out through the brainstem, and then you herniate, and then you die, right? So we don't want that to happen. So you got to be careful when giving free water to patients. That's why you never give sterile water for irrigation or injection. Like, you never give that by itself, because you can kill a patient very easily, because one, you're going to throw off their sodium and potassium in the blood, but also you're going to have this free water that rushes in all sorts of places you don't want it to. So never, ever, ever, ever give sterile water by itself. IV, okay? It's one of those big things. We actually don't let it out of the pharmacy because we're worried about people accidentally giving that. Okay, so that's D5. Let's look at, say, normal saline here. This 0.9% sodium chloride. Now, if you notice here, the amount of sodium and the amount of chloride here is equal to one another, right? Because sodium, chloride, it's 1-to-1 ratio there. Keep these numbers in mind, because this is important when you're comparing this to what your patient's serum sodium is. That normally this will have 154 milliequivalents per liter of sodium and 154 of chloride. So that means if I have a patient with mild hyponatremia, say they have a sodium of, say, 130, this is considered to be hypernatremic to that blood. I can use this to replace that, right? And remember, when we were talking about renal stuff, we said that in a lot of cases, if you have a hyponatremic patient, NS is usually the best thing to go with, because it's really hard to overdo it in terms of how much fluid you're giving them, in terms of overcorrecting that sodium there. But this is considered isotonic, because when I add these two up together, it's 308, right, which is pretty close to what our normal serum osmolarity is. So this is why we consider sodium chloride an isotonic solution. Yes, ma'am.
So at the ALPA conference, I went to a talk on fluids, and most of it was over my head, but they were saying that lactated ringers are now preferable over normal saline in pretty much like all the cases except for traumatic brain injury.
We'll talk about that. It's a very good segue. Thank you. Yes, so let's look at lactated ringers, right? So you may see ringers lactate, lactated ringers, they're the same thing, right? Now, what is lactated ringers? I'll go into the contents of it in just a few minutes here, but it's designed to be a little bit closer to what actual blood looks like in terms of electrolyte content. It also contains what? It contains lactate in it, right? And lactate, anyone know what that turns into in the body? Because normally you think lactate, you think, why does your body generally produce lactate? if you have a lack of oxygen maybe, or if you don't have enough energy to produce, go through the oxidative reaction cycle to produce ATP. Remember, your body kind of goes back to that Cori cycle and all that fun stuff, and it produces lactate, right? Called that anaerobic metabolism. Normally become acidotic. What's interesting here, by giving lactate to ringers, that lactate actually gets converted into bicarb. Bicarb is really important because what does bicarb do for us? Buffers the blood, right? So we'll talk about acid-base status in just a few minutes as well. But think about lactated ringers. And again, when might you become, slightly acidotic? Well, think about when you're in the surgical setting and you're being cut open and surgeons are doing all kinds of stuff to you. There can be cases where you're having this kind of mild acidemia that could develop, right? Mild acidosis. By giving that lactated ringers, that helps to kind of offset that a little bit, which is why you see a lot of lactated ringers in surgery typically, okay? Anyway, but you also find lactated ringers is isotonic, which means that when I'm giving this, in general, most of the fluid that I give will stay in the intravascular space, right? That is good if I have a patient who is hypovolemic, just like the patient we were just talking about there, right? You said the patient has been vomiting, having diarrhea, another hypotensive and tachycardic. Well, I know I need to get that intravascular space filled back up so I can give an isotonic fluid, and most of it will stay right there, okay? Not forever, but in general, that's what we're going to be seeing there. So in general, for fluid replacement, use an isotonic solution because most of it's going to stay exactly where you put it, okay? Now, let's look at the other ends of things. Let's look at hypo and hypertonic solutions here. Now, we mentioned D5 as being very hypotonic because it's all free water. Here we have, say, half normal saline or 0.45%. Now, notice here, instead of 154, the salt content is just half of what that is, right? That's why it's half normal saline, so it's 77 and 77 here. Now, again, if I were to give this to a patient, what could I accidentally cause? Because normal sodium levels is 135 to 145. I'm giving only 77 milliequivalents of sodium in a liter. Yeah, I can dilute out their sodium. I can cause hyponatremia. And in fact, that's why we're moving away from using a lot of hypotonic fluids like this, like half normal saline, because we cause a lot of, what do you call it when you cause a problem in a patient? Right, iatrogenic hyponatremia. That's a very common complication in hospital settings. In fact, for the most part, we've moved away from that in a lot of cases, at least in pediatrics, at least where I work. For the most part, most fluid orders are coming across as at least normal saline plus something else, right? But anyway, when you have the hypotonic solution, you're going to find that some of it will stay in the extracellular space, some of it will stay in the intravascular space, but some of it is going to be going into the intracellular spot. This can be useful, right? This can be good if you know that the cells maybe are a little dry and you want to try to replete that, right? So this is why sometimes for maintenance fluids, you'll see half normal saline being used. Once you've kind of tanked the vessels back up and they have enough fluid in there to support the blood pressure, then you can give something like a half normal saline, and that will allow the fluid to kind of slowly leach out into those cells and kind of replete them. So that's why you sometimes will see that in patients like gastroenteritis or kind of more long-standing sort of dehydration. You'll sometimes see that. Now, what can I do in terms of using a hypertonic solution? If I said hypotonic solutions will cause fluid to go into the cells and cause them to swell, potentially lyse in some rare cases, what would I do with a hypertonic solution? What do you call them? The cells start to shrink up and they crenate, right? So clinically, I've never heard that word actually used, but it's in all those physiology books, right? But it causes the cells to shrink, right? In what are cases where I might want to draw fluid off of spaces? Cerebral edema, right? We talked about that as being in cases where you have like head trauma, or say you have, say, a tumor or something like that. We can actually give hypertonic saline to try to draw fluid off of the brain by giving something that's very hypertonic. That fluid will rush out of those cells, and then we can impede that right out, right? So again, there are cases where I may want to draw water off of spaces, cases where I want to put water into spaces, and by choosing your solution, that's your solution to the problem, right? Bad fluid joke. Anyway, all right, so everyone got that so far, and that's why that negative number is here, this negative 2 liters roughly of free water, because again, you're sucking fluid out of the intracellular space, right? You're causing things to shrink generally, okay? Now again, 3% saline is another very dangerous drug you want to be very careful with. If you ever get your hands on some, be very careful with the dose because that's a lot of sodium, right? If you're giving too much of it, you don't want to cause too much cerebral shrinkage in terms of fluids. And also you can cause hypernatremia very easily. So again, very dangerous sort of drug, but very useful when you need to use it. So you'll see this a lot like in surgical ICUs or my neurosurge units and things like that. Okay. Any questions so far? Yes, sir.
Yeah, this is a silly question just to help me understand a little bit. So whenever you're putting a hypertonic solution into the vascular system of a patient, it's saying the 0 ICF, it's pulling from the ICF into the yeast?
Mm-hmm.
Okay.
Exactly. Yeah. So be able to, and again, I always use the example of like head trauma and things like that because that's where clinically it becomes the most relevant or most emergent. In those cases, I always go back to like emergency medicine kind of standpoint. But if you have that cerebral swelling, I can pull that fluid off and give the brain a little bit more space. You guys ever watch The Simpsons when Homer goes to box? He has all that extra like cushioning around his brain. He's got a lot of extra space, but a lot of people don't have that, right? Because again, their skull's a non kind of malleable sort of container for our brain. So again, we want to draw that fluid out. That's where we're using the hypertonic solutions there. You guys are quickly outdating most of my references here. No one's seen Hot Shots. No one's really seen those early Simpsons episodes. So you got some homework to do, okay? Gotta get back up on my level here. Anyway, so let's look at fluid balance here. So what are the general inputs and outputs? And this is something you're monitoring on your patients in the inpatient sort of setting. You're gonna be looking at what they're coming in terms of fluid and what's going to be going out. Very important because again, you want to make sure there's a balance there. The patient's starting off at a deficit. You want to replace them. You want to make sure it's not going to go too far in one direction where they're overhydrated, right? And the opposite is also true here as well. So let's talk about where fluids are going. So looking at fluid gains, we have sensible and insensible gains. What do I mean when I say sensible and insensible? Yeah, is it easily measurable, right? Can a nurse do that on a routine sort of monitoring of the patient? Can she measure the inputs and outputs? And so if it's insensible, it means it's really hard to measure. So I can't have a nurse go and say, well, how much oxidative metabolism do you think you've done today? How many mLs of water do you think you produced in that, right? Because remember the products of oxidative metabolism are water and CO2 generally, but you're going to find that it produce maybe about 300 ml, so clinically not super important for general adult patient, but oral fluid intake and solid food, right? Those are the main sort of sensible intakes of fluid you're going to be getting there for most patients. Most average healthy adult patients need roughly 30 to 40 mLs per kilo per day, right? Now again, this is widely can range depending on disease states, depending on a number of clinical settings, but in general, all of you probably need roughly 30 to 40 mLs per kilo per day, okay? Now, fluid losses, we both have sensible and insensible losses. Now, when I say insensible losses of fluid, what are those typically? Sweat's one, saliva. Hopefully you're swallowing most of your saliva, so maybe that's not going to be a net change. But if you have a lot of suctioning, maybe you could see that, right? If you're producing a lot of mucus and saliva, maybe you're suctioning a lot of that off. That's something that we don't usually measure. How about just the normal air or the normal water we lose just by breathing, right? That's another thing that's insensible. It's hard to measure that. However, urine and stool are going to be the big things we can measure, right? So how would I measure urine output, say, for a patient, like an adult patient? How do they normally do that? So you can just pee in a urinal, right? So you can, if the patient has the wherewithal to do so, they can just pee into a urinal. You can measure that and then dump it out, right? One way to do it. What else? Yeah, if you have a Foley catheter in, they can basically just measure it right there, right in the back. That's very easy. So you'll see that they have easy gradations there, so they can actually measure it and keep track of that. What do you do for like a baby? You can weigh the diapers, right? So you take what a dry diaper weighs, see what their diaper weighs now that it's full of urine, and then subtract that out, and you can basically equate that back out to how much urine output that would actually turn into, essentially, right? So again, lots of different ways we can do this. Obviously, the easiest is going to be if they have like a urinary catheter. What's the risk of having a catheter in, though? Infection, right? So again, that's another big case for iatrogenic problems we're causing for patients in the hospitals, giving them infections they did not come in with originally. So UTIs, ventilator-associated pneumonias, etc. So if anytime you can take foreign material out of a patient, it's always going to be good. But how about for teenagers? Like, you think it's super easy to do urine output? No, it's really kind of tough because again, we'll put patients on things like in classical. I think about my CF patients. I think about like aminoglycoside patients and vancomycin patients. Usually, those CF patients are in their teenage years. A baby, you can do whatever you want to, right? It's no problem. You have no issues of compliance. A teenager, on the other hand, though, they're like, well, I don't feel like measuring my urine. I don't want to pee into this urinal. It's gross. I don't want to do that. And they'll just dump it and not think about telling the nurse that they peed. So sometimes we have to go based off the number of voids they're having. Sometimes we don't get an accurate estimation. Just know that kind of goes along with the territory. So if you work with teens, again, you can tell them a million times, but they're probably not going to listen to you, right? Similar to young 20-year-olds, they're just not going to really listen for the most part, right? Exactly. So anywho, what are some reasons why patients may have overhydration, have too many fluid gains? What are some cases? No cases where a patient shows up overhydrated? CHF could be one, right? So they could have an inability to get rid of fluid, right? Maybe they're not perfusing their kidneys well, or they're having vascular backup because the heart's not working so well, right? So again, you can see that, or they're holding on to fluids. That could be one reason. What else? SIADH is another one, right? So again, they can have an inappropriate amount of ADH being released. We'll talk about ADH extensively here in a little bit in terms of how it affects fluids, but absolutely, so you can end up seeing too much holding on to fluids, because what does ADH normally do in the kidneys? Remember, it inserts those aquaporin channels into the collecting ducts, you're going to hold on to more fluid, right? Usually you're losing what ion? Lose potassium, we're going to hold on to sodium, right? So that's why you can see that potassium wasting for those patients there. Remember the RAS system? It's going to come back and bite you in the butt, like, right? Everything always comes back. It's all a big circle here, right? So anyway, so there's lots of cases of that. How about polydipsia? Why might a patient have polydipsia? Diabetes is a common one you think about. What are some other cases? SIADH is a big cause for that as well, right? Because you're engaging that thirst response. Any drugs that can do it? Like any medications or like illicit substances? What's that? I think about like ecstasy or Molly. That's kind of classically something that can, one, induce an SIADH, but also if you think about some of these amphetamine-based drugs that cause a lot of repetitive motions, and so some people will say, well, I need to drink lots of water because if I go to this concert and I'm overheated, I need to make sure I'm drinking water. They'll have this polydipsia where they're ingesting a ton of water. And on top of the SIADH, I'm seeing patients die after ecstasy ingestions. It wasn't necessarily an overdose, but they caused severe hyponatremia, seized and died, right? So there's cases where that could occur. Remember when I told you guys that story about the hold your wee for a wee contest, right? So again, that was a polydipsia that was self-induced. A person drank way too much water, was not urinating on purpose, and died from hyponatremia there as well, okay? Reason for fluid losses, what are some cases here? Vomiting, diarrhea, absolutely, number 1 and 2, literally. What else? Huh? Yeah, dehydration just due to a lot of insensible losses of sweat, right? What else? Diabetes insipidus, right? What drug causes that? Anyone remember? Lithium's a classic one I kind of think about for causing diabetes insipidus, right? So you're losing a ton of fluid because, again, you're having an irresponsiveness to ADH in the kidneys there. What are some other cases? What about if I had a patient who was, say, he was a bodybuilder and he was getting ready for a competition? Huh? Yeah, so you could abuse diuretics, right? So I've seen patients who have been abusing things like Lasix and loop diuretics to try to get off water weight to either meet weights for like a competition or a show or something like that. So you can see all kinds of reasons for patients to be dehydrated, right? And oftentimes not necessarily just the common ones you think about, but think outside of the box in terms of why patients might be fluid restricted. Okay. So in this case here, serum sodium, what do you think happens when the patient is overhydrated? Too much water on the system, serum sodium typically goes up or down? It's down, right? So they should have a hyponatremia typically. And plasma osmolality in that case would then be decreased, right? Because again, I'm diluting out the solutes that are in the blood, so you can see a decrease in osmolality, right? Osmolarity. On the other side of that, if I have someone who's dehydrated, what typically happens? Their serum sodium should probably go up in most cases. Again, it's not all cases, but in most cases. And then how about the osmolarity? It will also increase, right, because you're concentrating the blood, right? So again, you're going to find that there's more solutes per unit of measurement, and so it's going to have a higher concentration there. Osmolarity is going to go up. Now, again, what hormone's the biggest one? We already talked about it. ADH, right? So what are some causes for having ADH being increased in levels? Tumors can do it, right? Tumors can secrete ADH for sure. What else? Hypovolemia in general induces ADH release, right? What else? Pain can do it. Nausea, vomiting can do it. There's a lot of physical stress that goes into illness that you can see can actually increase ADH levels, right? So that means more ADH means that I'm going to be holding on to more free water. What does that do to my serum sodium? Usually hyponatremia develops, right? Remember, SIADH is one of those cases where you have a euvolemic hyponatremia. Typically, you're diluting out that sodium there. The patient may not appear fluid overloaded, but their serum sodium is low, right? So these are all things we talked about before, but again, they're coming back. Think about how it's going to be presenting in a patient. Think about things that can cause these different disease states to occur here, right? Anyway, so we'll get more details on that. But just remember that in terms of hemodynamic stimuli of ADH here, you're going to find that obviously volume depletion, hypotension, CHF can do this, cirrhosis, anything where the kidneys don't think they're getting enough blood flow or there's not enough salt, ADH is going to be one of those components that gets released, right, in addition to all the other stuff in the angiotensin aldosterone system, right? Looking here, pain and stress, nausea, vomiting, all these things can end up leading to further release of ADH. And again, that can cause one of those euvolemic hyponatremias. Usually osmolality is going to go down in those cases there because, again, there's just more water sort of diluting out the solute in the blood. Cancer, as we mentioned, tumors can do this, CNS disease. You can see this with cases of head trauma where they'll have an SIDH. Remember I was talking about in the surgical ICU and a patient was like almost about to sell their own grandma so they can get some Gatorade. They were so thirsty from all the ADH that their brain was secreting, right? It wasn't their fault of their own, it was just the fact they hit their head in a car crash and all of a sudden now all this ADH is being released, right? So anyway, those are important to consider. Now, looking at electrolytes, right? So when we talk about like main electrolytes, we talked about a few already. What are the main components that we're thinking about usually? Sodium, potassium, chloride's important. What else? Calcium is another one you typically we are concerned about, right? Because we worry about that with like muscle contractions and things like that. What else? Phosphate's another one you'll measure. Magnesium, as a lot of docs will say. What else? Those are the big ones, right? So those are the more common ones you're going to be running into. You want to be measuring. Now, what comes on your Chem 7, your BMP? Sodium, potassium, chloride, bicarb. It's not an electrolyte typically, but it's very important when you're considering electrolytes because, again, depending on acidosis and things like that, that can play a role. What else is on there? BUN, creatinine, glucose, right? So, again, that's your total Chem 7. Normally, you don't have a calcium, a mag, and a phos on there. If you do like a CMP, those will usually be added on, or you can measure them independently. You can order it separately if you want to. But just think about it. If you get a Chem 7, you're really only going to get your chloride, your sodium, and your potassium on there. The rest of the stuff is not going to be measured directly, okay? Something to think about. But anyway, again, looking at things like, well, if I have a patient who's having a lot of vomiting, well, what could that lead to losses of in terms of electrolytes? And that will make sense here when you're looking at things like, what are the stomach contents? Stomach usually has a lot of what in it? Hydrogen and chloride, right? So if I have a patient who's vomiting a whole lot, what do you think it would do to their acid-base status? So remember, what are my balancing factors there? When say you're doing an anion gap measurement, how do you measure that? There's your positives minus your negatives. You have sodium minus chloride minus bicarb, right? Some people say minus chloride plus whatever. You're putting your negatives together. So bicarb, chloride together, measured, subtracted from your sodium, right? So again, if that gap is increased, that shows you're having an acidosis going on there. Well, if I have less chloride because I've been vomiting it up, you can see an alkalosis that can develop there, right? On the other hand, what if I was having a lot of diarrhea? They tend to become acidotic because they're pooping on a lot of bicarb, right? Because again, you secrete a lot of bicarb there, especially in the later stages of the intestines and the colon. So again, think about it. If the patient's coming in having a ton of diarrhea, like they are going to be presenting one way. They might have certain electrolyte shifts that occur because of that, versus if they're coming in just purely vomiting. Again, think about the clinical implications of this as we go through and talk about these other things. So usually when you're correcting fluids for patients, you want to think about how fast you're fixing things, right? So again, is the answer to always go as fast as possible? No, right? Not always, right? It depends on how much sort of homeostasis has started to kind of kick in, how much sort of compensatory mechanisms have started up. Typically, if an issue is less than 48 hours old, you can correct it pretty quick, right? The body has not had a lot of time to equilibrate, especially when you think about fluid shifts and electrolyte shifts between the normal extravascular space or extracellular water and the CNS. Again, that's one of the big concerns we have there, because again, if that equilibrates and I shift the extracellular fluid drastically, you're going to see there's some issues there, fluid shifting causing cerebral edema or cerebral shrinkage, things like that. So usually if it's less than 48 hours, you can fix it fairly quick. If it's more than that, typically you want to be a little bit more slow with it. And again, that's why we talk about correcting hyponatremia. What's the big risk if I correct hyponatremia too quickly? Central pontine myelinolysis, right? So because of that, or that osmotic demyelination syndrome, however you see it termed. Again, that's an issue if we're correcting the sodium too quick. That can strip all the myelin off your neurons, right? So it's a big concern for those patients, and depending on how quickly they present. So I'll give you an example. When I was on rotations, I was at a PICU, or not PICU, it was an adult ICU. I met this lady, I mean, she was probably like in her mid 40s, never worked out a day in her life, and decided, July 1, middle of the summer heat, she said, I'm going to go to boot camp, or one of those like fitness boot camps. And guess what she did? She got in the sun, she sweated a ton, losing a ton of fluids. Do you think she drank enough water? No. So she comes in, she's dehydrated, she's hyponatremic. Now, that occurred over the course of, say, a few hours. So could we correct her pretty quickly? You could, right? Remember, what's the max amount you want to correct a sodium in 24 hours usually? Yeah, usually no more than 12 milliequivalents in a 24-hour period there. Well, we accidentally screwed up and overcorrected it, right? There's miscommunication between the ED team and the ICU team, and they overblew it. They went past that 12. For her, that patient, it was not as big of a deal because it was a very short period of time to which the hyponatremia and the hypovolemia developed to when it got corrected. Now, if this had been a long-standing issue, say over the course of, say, 3 or 4 days, then it would have been another story. That's when you're more likely to run into those issues of that demyelination syndrome and things like that, because the brain and the rest of the body has had time to equilibrate to those changes. Okay, so just know that if it's a fast change, typically you can fix it faster. If it's a long-standing change, you got to be slow with it. Okay, you can always give more. It's hard to take it back when you mess something up like that. Okay. So looking at what are our goals when we're administering fluids to our patients. Usually we want to replace or maintain the fluid balance, right? So again, to come in dehydrated, get them back up to normal, and then you want to maintain that, which is why we always talk about fluid boluses and the maintenance rates. We want to maintain our electrolyte balance, right? Because again, we can't just give them pure sodium chloride ad infinitum, because you're going to find they're going to lose things like potassium in the urine. They're going to lose magnesium and phosphorus and things like that. Okay, and then also we want to consider giving them calories to prevent catabolism. Catabolism is what? Breaking down the body, right? So, as opposed to anabolism, where we're actually building things back up. So that's why we usually include dextrose with a lot of our fluids, because that is at least providing them some calories. They're not going into a full-on starvation state. Now, again, is that going to be, if I give someone D5 normal saline, is that going to take care of all their nutritional needs? Generally, no, because that's only one of the macronutrients we're really concerned about, right? What other are my other macronutrients I care about? Proteins and fats, right? So again, it's not going to take care of everything, but for the short term, if a patient's being admitted for an appendicitis and they're going to be in the hospital for 2 or 3 days, not really a big concern, right? Our bodies usually have enough stores where it's not going to be as big of a deal in the short term. Anyway, so some other things we're going to be looking for, we can do with fluids. We can maintain pH, right? So if you have a patient who's acidotic, I can give them bicarb, and I can try to get their pH back under control, right? Now, would I ever try to acidify a patient? Typically, no. Patients are pretty good at acidifying themselves. We typically are not going to give them hydrochloric acid to try to acidify them. It's usually not something we do, right? But we can give bicarb. We can try to get their pH back up if need be. We can also provide oncotic pressure. So imagine you have someone who's severely malnourished and maybe they weren't producing a lot of their own serum proteins. We can supply that, right? We can give them albumin. We can give them other proteins back potentially. And then we can try to prevent things like precipitation of metabolic byproducts. So remember, in cases where, say, you have a lot of muscle breakdown, like in the case of rhabdomyolysis, again, the muscle breakdown is bad, sure, but we really worry about that myoglobin precipitating the kidneys. When that happens, everything gets blocked up, and now you have kidney injury, potentially failure, potentially need for dialysis. Same thing can happen with certain drugs. Do you guys remember any drugs that can crystallize out in the urine? Methotrexate. What else? Acyclovir is another big one, right? Ganciclovir, all those drugs for herpes, things like that. Those tend to do it too. Get that crystalluria that can develop. So again, these are all things we can do with our fluids. These are oftentimes the goals that we're trying to reach here. And so now we can start to look at the type of fluids we're going to be administering, how much we want to give, etc., based off of these goals here. So what routine fluids are available, right? So you can write for whatever you want on your magic prescription pad, but when that order gets to the pharmacist, one of two things can happen. I can say, well, it looks like a routine fluid. That looks pretty good. I got that in stock. Or if it looks like something crazy, what am I going to do? I'm going to call you and be like, no, you need to write for one of these other things, right? I'll be nicer than that, typically. But I'll say, this looks a little crazy. Let's try to get this fixed, right? Actually, it's so funny because I had to call down to the ER, not yesterday, but a week ago. I called down. I was like, this doc's writing something crazy. And I called down there, and guess who it was? The PEDS ER and the Moores. Dr. Nicholson. I was just like, oh my stars. Look who it is. Of course, so I chat for 10 minutes, and I'm like, oh wait, I totally called for something. Let me get this order fixed. Anyway, right. So looking at this, we can see that routine fluids, as far as sodium content goes, normal saline 0.9%. Right. So when you're writing that out, if you write 0.9%, That is referring to normal saline there, right? 154 milliequivalents of sodium per liter. That is kind of the standard. That's normal. That's what I call it, normal saline, right? If you have half normal saline, that is 77 milliequivalents per liter. That is sometimes good for shifting water into which space? Intracellular or extracellular? There's hypotonics, going to shift it into the intracellular space, right? And then we have quarter normal saline. Again, this is even less sodium, even a bigger risk for causing hyponatremia. We don't use it quite as often. You may see this being used in more cases of patients like NICU patients or very, very young patients. You may see this, not typically used for adult patients unless they maybe are dealing with, hypernatremia, okay, because I'm able to get that down a little faster. Now looking at dextrose concentrations, the most common one you're going to run into is which concentration? D5 is far and away the most common. You will see things like D10 being used in cases where maybe a patient is hypoglycemic and you're trying to get their sugars back up, or in cases, say like in the NICU, when you're dealing with those young patients, again, they're very highly metabolically demanding. You may give them higher concentrations even than that, okay? Now, when I'm giving like total parenteral nutrition or TPN, you may see, D12 and a half, D15, D16, so you can get higher concentrations than that, but D5 and D10 are the most common you're going to run into. D5 far and away the most common. But remember, you typically don't want to give it by itself because of what is it? It's all free water, right? Most of it's going to end up where? In the intracellular space, right? So I have no salt to try to hold it back in the intravascular space, so it's all going to leach out and go into the cells, okay? But again, it's good because it provides what for my patients? Right, calories, provides energy for them, right? So again, for every gram of dextrose I provide for a patient, how many calories do I get from that? Anyone know besides Ashley? 4, right? So remember your macronutrients. This is a good number to remember. For every gram of carbohydrates, you get how many calories? 4. For every gram of protein, again, you probably have more specific numbers, but just to keep it easy to remember, how many? 4. And for fats, it's what? 9, right? Because again, fats are very highly energy containing. They provide a lot of energy there. That's why we have a lot of fat stores, because if we're in a starvation state, we can get extra energy out of that, right? So just remember, those are good numbers to remember when you're trying to figure out, well, how many calories am I providing for my patient? You can figure it out based off how much dextrose you're actually giving them, okay? And we'll talk about that a little more in detail in a few minutes here. Now again, getting into lactated ringers, you'll see here, again, very similar in terms of osmolality, very similar to what our blood is. And if you look at the actual concentrations here, it is very similar to what you'll see in normal blood in terms of electrolytes. Sodium of 130, a potassium of 4, we said 3.5 to 5 is pretty normal there. Has some calcium, has some chloride, and has that lactate. And again, what's a normal bicarb on a BMP? I usually like 21 to 28, but somewhere around that range there, right? So usually the low to high 20s is generally considered pretty normal for patients. Again, it's providing 28 milliequivalents per liter. That gets converted into what? That lactate. The liver will convert it back to bicarb, right? So again, that's why in cases where you might have a patient who's a little more acidotic, like in cases of surgery, this is why you see that being used more often, right? It's considered more natural, more similar to what the actual patient has in their blood at any given time, okay? Someone made a very good point, and it's good bears repeating, I think, just to clarify, to make sure everyone's on the same page here. Now, when I say a Chem 7, I talk about the bicarb. Normally, that gets denoted as what? What's kind of the chemical symbol they use there? HCO3, right? You guys remember the carbonic anhydrase enzyme? Remember all that fun interplay between carbonic acid and CO2 and all that fun stuff. So again, when you say bicarb, that's HCO3 that you're really talking about. Now, you may sometimes see that bicarb gets converted over into what byproduct? CO2, right? So you're going to eventually get rid of those acids and things by blowing off that CO2. Sometimes on a Chem 7, you'll see a bicarb being denoted as CO2. That's okay, right? They're the same thing at that point. Now, when it's measured, it'll say milliequivalents per liter, right? So that's the actual content in the blood, how concentrated it is. That's that 21 to 28 that we talked about. Now that is different than when you're talking about, say, like an ABG, and you look at the CO2 there, right? Because again, what am I measuring there on an ABG? It's not the content, it's the partial pressure that is being exerted by the CO2. Now when you talk about a normal PCO2, what do you consider that to be? Say like an ABG. 35 to 45. What is the units on that?
MMHG.
MMHG, yes, millimeters of mercury, right? And again, you're not actually measuring out like strings of mercury, but again, that's how they measure that stuff on the initial, like the tools they were using, right? We don't use mercury anymore; it's highly toxic. But millimeters of mercury, that's the pressure that's exerting there. That's why you have that discrepancy. A normal bicarb level is 21 to 28, but the partial pressure should be somewhere between 35 and 45. Okay, everyone get that? So again, if I have a high bicarb level, am I alkalotic or acidotic? You're usually alkalotic. If I have a high PCO2, am I alkalotic or acidotic? Acidotic, right? So remember, there's that interplay between the two, because as you get more acidotic, as you have more hydrogen ions, you shift away from bicarb into forming more CO2, right? So again, your body's trying to get rid of that. That's why PCO2 will climb when you're producing too many acids, when you're in a more acidotic sort of state. So keep that kind of interplay in mind between what you're actually measuring in the blood, say on an ABG, versus something like a Chem 7. Everyone with me? Fantastic. All right, if not, you can come up and ask questions. But so we talked about crystalloids, the common ones you're going to run into. We also have our colloids. Again, these are typically going to be albumins, the most common one you're going to run into. You also have some starches like hetastarch and dextran. These are used less commonly. They're typically more expensive. They don't really show any clinical benefit over using a crystalloid. So in general, your default should be using a crystalloid over a colloid. Now, if you have a case of a patient, as I mentioned, who's maybe extremely malnourished, maybe their albumin levels are low, or maybe you need to replace albumin, this is where that can be important, right? So we use this a lot in cardiac cases. We'll use this a lot in patients who maybe have low oncotic pressure. And so there's two main concentrations you're going to run into there. There's 5% and 25%. 5% is going to be good for volume replacement. So as I mentioned, that patient who's getting apheresis and they're having 2 liters of plasma being resupplied to them, because again, we're pulling off all their plasma essentially, and we're giving them 4 liters of albumin. That was 5% albumin, because again, it's going to be providing oncotic pressure along with volume. It's less concentrated than the 25%. 25% is if I want to give a smaller volume and I just want to get that protein. So as an example, if I had someone who is, say, euvolemic, but I wanted to give them that extra albumin, I can use that 25%. It's less volume in general, okay? Anyone remember a normal fluid bolus dose? Say like normal saline? Or a bolus a patient, it's, you should know this number, 20 mLs per kilo, right? If you're dosing 5% albumin, guess what the dose is? Roughly 20 mLs per kilo, right? So again, you get very similar activity there between, say, like a normal saline bolus versus the albumin 5% bolus there, right? So again, those are dosed very similar. Usually you'll find the 25% is usually based off of how many grams of albumin you want to give to the patient. Okay, so there's something you'll note there when you see those orders is that albumin 5% normally dosed in mLs. The higher concentration, 25% normally dosed in grams, right? You'll see that when you actually get out there and see patients who are on the medications. Anyway, so again, what else would I want to add to my fluids? We said normal saline is good to have because, again, that provides sodium for our patients. It provides good volume to stay in the intracellular or extracellular space. We want to provide dextrose because that'll give us some calories, some energy. What else can we put into our fluids? So normally think about D5NS with 20 a K, right? I always say 20 a K. K what? KCl is most common. Potassium chloride. What else is common you think you might run into? Sometimes you'll see things like potassium phosphate. That's good because that helps provide a little bit of phosphate. Sometimes you see potassium acetate. Lots of different varieties there. But usually KCl is going to be the most common one you're going to run into, right? Or your CLA. I actually had a patient came up to the pharmacy one time. I was rotating at a Walgreens. They said, "Oh, can I pick up my CLA?" And I was like, "What are you talking about?" It's KCl. You also need Huctaz. You know what that is? HCTZ, yeah. Patients will come up with all kinds of crazy stuff. But anyway, so the reason why we want to add potassium to these fluids is to replace kind of ongoing losses, right? Because again, we know we're going to lose some amount of potassium out of the kidneys, especially in patients who have a high amount of ADH they're secreting due to pain or vomiting, because we said ADH is typically going to be losing some potassium there, right? Also, aldosterone is probably going to be upregulated. You're going to lose some potassium there as well, right? So looking at that is very frequent. You'll see a fluid order, maintenance fluids, or D5NS with 20 a K, or maybe 40 a K, depending on what their potassium level is. Now, if a patient was admitted and their potassium is, say, 6, would I want to put any potassium into their fluids? No, because they're already hyperkalemic. I don't want to do that. But if they come in and they're 3, would I want to do it then? Absolutely, because they're hypokalemic, they're below the normal level there. Okay. Sodium bicarb can be used. Oftentimes we'll use this for the process of alkalinization. What does that mean? We're trying to make our patients as basic as possible, right? try and get them their pH up essentially, right? So again, if they're having a metabolic acidosis, we can give them bicarb instead of sodium chloride, and that will actually help them get their pH back up. Because if I were just to keep giving sodium chloride, that chloride, guess what? Makes them a little more acidotic. You can develop an acidosis from that hyperchloridemia. So I can give bicarb instead occasionally. And so notice here that when I give sodium bicarb, it's going to replace sodium chloride 1-for-1. So as an example, if I wanted to make, say for instance, the equivalent of normal saline with sodium bicarb, I would actually use sodium bicarb 150 milliequivalents and put that into a bag of D5. And now I have 150 milliequivalents of sodium. Now what do we say normal saline has in terms of sodium? 154, right? So again, this is very, very similar. So again, that's something we could use. I use this quite frequently in tox cases. We'll use this for TCA overdoses. We'll use it for aspirin overdoses. And I'll say you give sodium bicarb 150 milliequivalents in a liter of D5, and that will be used for alkalinization purposes. It's very common. We'll do that. And again, if you don't have sodium bicarb, something you could use instead is actually in an acetate form, either potassium acetate or sodium acetate. Acetate will turn into bicarb eventually, just like lactate does. Acetate can also turn into bicarb. Okay. Okay, some other things you may find, again, depending on if you're giving parenteral nutrition, which means IV nutrition, you may find amino acids are being given. Amino acids are basically what? Protein, right? So you're basically giving protein to our patients if they cannot take it enterally or orally for a long period of time. We can give it to them in the IV. Other electrolytes might be added, things like calcium. Now, what major forms of calcium are you going to find in IV additives? What salts? Calcium chloride is very common. Calcium gluconate is the other more common. Is the other one you're going to see very commonly, right? Now, if you think about like your Tums, what kind of calcium salt is that? Calcium carbonate, right? So again, we're not giving that. We're giving calcium chloride or gluconate. Remember any issues with giving calcium chloride? We talked about it when we talked about like emergency medicine meds. Yeah, calcium chloride is really, very hard on the veins. So again, when you're thinking about giving these fluids, think about what kind of access you have, right? Peripheral versus central access. When I say central access, what do I mean? Usually it's going to be a catheter that's emptying out into the vena cava, right? Typically it's going to be either like a port that's implanted or a line that's being placed, either like an ephemeral vein or something like that. But by giving this directly into the IVC, what's the benefit of that? It's a lot of blood flow, so it dilutes out whatever drugs I'm giving through that line very quickly. I can give higher concentrations of drugs. I can give drugs that are very hard on the veins because again, it's being diluted immediately and going straight to the heart. So calcium gluconate will easier on the veins. I'll like to use that in usually more peripheral lines versus calcium chloride can be used in more central lines. That's something you also want to think about when you're thinking about access for your patients is like, do I just have like an AC I have access to, or do I have a central line that I have access to? Because that'll be very important in determining what kind of concentrations of meds you can give, how much you can give, etc. Okay, so just another consideration there. Okay, which one do you think I can get higher flow rates through? Usually central access, but also depends on the actual size of the catheter itself, right? So again, thinking about when you're talking about large bore IV access, right? What does that mean? Think about that. Yeah, using like a 16 gauge, 18 gauge, something like that. Maybe 14 if you really mean to the patients. But obviously, the larger the diameter of the catheter, the more flow you're going to get through there, right? Remember, it's like I think the radius cubed almost. I think it's to the fourth power even. So again, that radius there is going to make a big difference in terms of how much volume you can get through there. So we'll talk about that in just a few minutes here. But other things you might give, other electrolytes, as I mentioned, magnesium, phosphorus, and then lipids is another thing, right? So if you ever give lipids, if you ever see a drug come in a nice milky white substance, like propofol, you commonly see that. Or if you just see a bag of white substance looks like milk you're infusing into your patients, that's usually intralipids that you're giving to them, okay? Okay, so let's go back to our case here. So we said we have our patient here who's we said is dehydrated based off the vital signs, based off physical exam. So what kind of fluid bolus do you want to give him? And in fact, let's see if I have any volunteers who would like to write fluid orders for this patient. You've all had experience with this. I know you can all do it, and I believe in every one of you. I'm sorry? I do. I remember yours quite well. In fact, would you like to volunteer? This is easy. We'll do it together. We'll go step by step. Who is going to be the brave soul before I have to call on somebody? I don't want to do that. All right, let's go. Let's go, Kyle. You raise his hand first. You volunteer. We can go with you next if you want. David. All right, Mr. Kyle, come up to the board. Everyone's going to help you out as well. All right, so do you have a marker, hopefully? Otherwise, this will be in vain. All right, so what kind of fluid do we want to administer to this patient? Okay, good. So initially, we wanted to go for fluid repletion, right? We want to try to get the intravascular volume filled back up. So in that case, we can use what? Normal saline, right? Okay, so how much do we want to give this patient? Okay, yep, good. So we're going to start with a bolus. Very important point, right? Typically, when you want to get that volume back up quick, a bolus is going to be good. How much are we going to give? Okay, good. So 20 mLs per kilo is a very good starting bolus. So that's typically the default we use for children. For this adult patient, what did that turn into? So 8 times 20, or 80 times 20 would be what? 1,600 mLs, right? So do you think you're going to write 1,600 mLs for an adult patient? No, what would I say instead? 2 liters, right? Easy. So, okay, so let's go ahead and start off. We're going to say what fluid do we want to give first. And again, we can use some abbreviations here. So we can say, okay, good. So you can either write 0.9%. So you could write NS. To be more specific, you could write NaCl, right? Because again, that's what you're denoting when you write that 0.9%. That's specifically what you're referring to. You could just write NS by itself. That is generally understood to be normal saline. Okay, so either one of those will work. Okay, so we have our fluid that we're going to give. Now we're going to give with our amount. We'll get to that in a second. So let's go ahead and get our volume that we're going to give. 2 liters. You could write 2,000 mLs if you wanted to. Either of those would be totally fine, right? What's our route? So you can just say IV, right? So again, the route can be very general there. You can just say IV. What else do you want to know? The rate. How fast do we want to give this? So when you say bolus, typically that just means you can give that as fast as possible. Normally that's like letting it run to gravity, or if you have a pump, just setting on the maximum settings. So this is important because for pediatric patients, you want to be more specific and say, well, how fast do you actually want to give that? An adult patient like this, probably not so concerned. You can just write IV bolus, right? And that probably just means the nurse is just going to run it as fast as she can to get it in. We'll talk about different ways we can get fluids into the patient a little bit faster, but that is one way to start, right? Otherwise, you could say, well, let's do it at, 1,000 mLs an hour. Obviously, that's going to take 2 hours to run it in, so you normally want to go a little faster than that. But we'll talk about that in a second. Okay, good. So we have our fluid bolus. That's one way to start out with. Now, obviously, if the patient had like renal failure, if they had CHF, and they looked kind of edematous, but they're still intravascularly depleted, because again, it seems kind of oxymoronic, but you can see patients like that. You may want to start off with half of that, right? So maybe start off with either a liter, maybe 500 mLs. It just depends on patient situation. Okay, so that would be our bolus. Let's say we want to write for some maintenance fluids as well. What type of maintenance fluids do you want to write for? Okay, so what's half normal saline going to do for us if we did that? So if you want to try to replete the more intracellular space, like that would be one way to do it, right? What's our risk, though, of doing that? Hyponatremia, right? So again, it's kind of a double-edged sword in those cases. There, in general, you can't go wrong with using normal saline, right? Again, eventually that fluid's going to seep into the intracellular space. It just may take a little bit longer, right? So again, clinically, it probably won't make a big difference, but my risk of hyponatremia is less, okay? So I can use NS. Do I want to give anything with that? Okay, so I want to add some potassium in there. Anything else I want to give with it? Say the patient's getting admitted, he's NPO. Can't tolerate any orals. You want to get some dextrose, yeah, absolutely. So you want to make sure you give him some sugar along with that, so that way he's going to have a little bit of energy, doesn't go in a full-on catabolic sort of state there. So normally when you write your maintenance fluids, you're going to start off with the dextrose content. So how would you write that? Dextrose, you write all the way up. So you could write 5% dextrose in water. That would be the long way to do it. What's another way to shorten it up? D5W, right? So you could write D5. Actually, some people just write D5, and that's kind of understood to be dextrose 5%. D5, and then what next? 0.9%. So let's shorten that up even. Let's not even write the 0.9. Let's just write D5 NS, right? So D5 NS. Now, if I wanted to say write for half NS, you could just put a half in front of that N there, right? So that's one way to do it. Okay, so D5 NS. And then how would we want to add our potassium in? What do we want to use? Okay, so when you use potassium chloride, it's a very good default to go with. How much? 20 what? Good, 20 milliequivalents per liter, right? Good, and that's a very standard maintenance fluid you're going to run into, right? So how would you write that? So I would just write a W, and then a slash for width, and then write your potassium. Fantastic. Yeah, some people might do the 20 milliequivalents per liter KCl first. May switch that. It doesn't really matter, right? So now we said, okay, now we have our fluid that we want to administer. Now what do we need?
Rate.
Good. So you want to rate, right? So again, we're going to give our D5NS with 20 of KCl. A rate. So let's try to apply the 4-2-1 rule to this patient. Let's see what that would come out to be.
So for the first 40 kilograms, it's 2.
Remember, for the first 10, it's going to be 4 mLs per kilo. For the next 10 is what? Be 2 mLs per kilo. So now we got 40 plus 20, and now how much do we have left over? We got 60 mLs, or 60 kilograms left over, and that's 1 ml per kilo, right? You guys remember, just go back and practice this stuff. I know you've done it before, so I know you can do the math. But again, so for a patient like this, it would be 40 plus 20 plus 60, making a total of 120, right? So 120 mLs an hour would be a totally appropriate maintenance amount for this patient here. Again, the default for most adults is 125 mLs an hour. That'll give you roughly 3 liters in a day, okay, which is generally what's required for most adult patients. So, right, so you can write 120 mLs. And so most people write just slash hour, but you can do that too. Okay. Now what else do I need? Need your route on there as well, right? So IV, good. Now when you write something that just says, say 120 mLs per hour, it's understood to be continuous. Unless you wrote for 2 hours or for how many ever hours, it's understood that's going to just run continuously until you say stop or until some other provider comes along and DCs it. Okay? And that's appropriate. That's totally fine order. So you can say followed by if you wanted to after the bolus. You can do anything you want like that. Typically you'll find the boluses will be administered by the ER providers, and then the admitting people will do the maintenance fluids. But that's generally how you would write it. It's just that simple. Okay.
If we did use lactated ringer, would we still have this 20?
Not necessarily. Depends. Normally you may find like D5 LR. Normally LR will be given by itself in the more surgical setting. I'm trying to think, do I ever see? Now again, in the pharmacy, we can make whatever we want, right? So we can always add stuff together. We can concoct all kinds of different solutions. It's not, we don't like to do it. Why is that? Because we're lazy? Possibly. What else? It could be more dangerous, right? KCl is a very dangerous drug in the wrong hands. In fact, what are the 3 drugs they use to do lethal injection? Usually use a sedative, usually use a paralytic, and then what's the last thing? KCl, right? These KCl to stop the heart and open heart surgery, right? So it's a very dangerous drug. So we can avoid having to make our own solutions because we're having to handle the more concentrated forms. That's always beneficial. So if you can use something that's pre-made, that's fantastic, right? The nurse can go to the Pyxis, pull it out of the station, they're good to go, right? Thank you. You can sit down if you want. So for LR, you just write LR, same thing. If you want to write D5 LR for maintenance, that would also be an alternative, right? So good. So again, it's just that simple. It's just like the orders you've already done on your prescription assignments from Pharm 1 and 2. Okay. Again, use your abbreviations where appropriate to try to shorten that up and make it a little bit quicker for yourselves. Okay. Now, in the real world, what are you going to do? You're going to click a box on your order set, and it's going to be as simple as that. You won't have to think about it. Everything's defaulted in already. But if you were to write it on paper, this is what you'd be doing. Okay. Anyway, so as I mentioned, usually adult. Oh, yes, sir.
So just for the age range again for peds, is it about 8 years old? Is where that cutoff is for giving 2 liters? I'm just wanting to see them. So
I use it more on just based off the weight. Typically, for pediatric patients, we can always give more fluids, right? So in general, even up to an 18-year-old, start with a liter. If you need to give more than that, you can. But some people will say, they'll write for 2 liters in succession, so that way there's a little bit of a downtime in between. You can kind of recess the patient and then give the next bolus. It just depends, right? So typically, though, you top it off at a liter, right? And so you'd hit that at about 50 kilo patient or so.
It's about 50 kilos.
Yeah, because 50 times 20 would be 1,000, right? So that's where you get your 1 liter there. Yeah, so that's kind of the cutoff point there. Good. Yeah. So and again, you can apply any of these 421 rules, the 20 mLs per kilo to adult patients, totally appropriate, right? Just not done as frequently because usually for adults you kind of go to defaults for a lot of things. But as I mentioned, you have a patient who has renal issues, renal impairment. They are very edematous. You may want to be a little bit more gingerly with how much fluids you give. 10 mLs per kilo, or say 500 mLs to start off with. Okay. The reason why that is because we can always give more fluids, but how do I get fluids off of the patient if I give too much? I can either give diuretics, which now I'm adding on more drugs than what I need to in the first place, or what could I ultimately do? Dialysis, right? So again, you may find you have these patients who are renal patients who maybe they skip their Friday dialysis. Now they're coming into the ER Sunday morning, 3 a.m. because their uremic is all get out and their potassium's 6 and their heart's starting to palpate. It's those are the typical thing you're going to run into. So in those patients, you got to be really careful with the fluids you're going to be administering for them. Anyway, so as I mentioned, fluids use NS 9 times out of 10. Now LR is generally relegated to the surgery realm, and you'll find that in most places. Now, to your point, Angela, when you're talking about that talk you went to, is LR incorrect to use elsewhere? No, but it's just generally not done. Now, in 10, 20 years, might I be preaching something different? Quite possibly, right? Because medicine is slow to change, but it does change over time. They quote that by the time an original piece of research hits a publication, how long before it becomes clinical practice? Like 17 years or something. All right, so again, it's a slow process, and in general, you're going to find that LR is a little bit more expensive than NS, and so that's usually it's more of a cost consideration why it's kind of kept in just kind of one realm there. But there's nothing saying that a PICU doc or someone working in med surg floor could not order LR. There's no reason they can't do that. It's just not usually what's done. Anyway. For some patients, if you're continually repeating boluses of NS, that can be tough because that extra chloride amount. Because again, think about our normal chloride level in the blood. It's usually in the kind of low 110s. What's the chloride content of NS? It's 154 milliequivalents per liter, just like the sodium. And so you can't have a hyperchloremic acidosis that develops, in which case it might be a good idea to switch over to using something like LR in those cases there. So that's one thing you may see occasionally. Again, there's no big benefits to using colloids. They can cause renal issues. They can cause bleeding issues. So use crystalloids. Again, it's cost effective in the long run as well. And again, think about patients who might need a lot more fluids. If they're coming in, they're severely septic, they're having hypovolemic shock, you may find you may need 60 to 80 mLs per kilo. That's not all in one bolus. You would be giving repeated boluses, but they may need up to that amount in order to get them adequately resuscitated. Okay. How do you get fluids into your patients, right? So you can find that a lot of it's dependent on the cannula gauge, right? So again, if you're putting in a 14 gauge, you're going to get a lot more flow rate possible than you would if you were to put in, say, like a 24 gauge. So because of that, that is a consideration, right? Now, think about pediatric patients. Can they get a big 14 gauge put into their AC? Think about we have some neonates in the NICU right now that are 600 grams. Incredibly small little peanut, right? No, you can't put a 14 gauge. It's as big as their eye probably, right? So because of that, there's a consideration about how big of a cannula you can actually get in. Now, normally with gravity alone, if you just let a bag run to gravity, it's about 120 mLs per minute through a 14 gauge cannula. So again, it's some fluid rate, but if you want to get a liter in, you're going to need to go, you get in pretty quick, roughly, 8 to 10 minutes or so, it should be able to go in. What if I want to get that in faster? What could I do? Well, that's where you can use pressure bags, right? So here's an example of a pressure bag put over a liter of saline. You can just pump that up. Now, what could I use if I was in a bind? Yeah, you can use a blood pressure cuff and do the same thing, right? So you're increasing that pressure to increase that flow rate. But ultimately, you're going to be restricted by the radius of that cannula that you've inserted into the patient there. So start off bigger to begin with, you're going to get more flow rate, okay? Now, most standard pumps, this is a Lars pump. This is a very common thing you'll see used in a lot of hospitals. The fastest these can run, 999 mLs an hour. It's not very fast when you're thinking about you need to get 2 liters into a patient real quick, right? That's going to take too long in some cases. They really need to be resuscitated right now. And so those are things to consider when we may need to switch off of that to use something like a pressure bag. Now, if I'm giving 2 liters to a patient, like that's all well and good. That's just 2 bags. Well, what about if I had that 600 gram neonate and I want to give a 20 ml per kilo bolus? How much am I giving? Yeah, it's not very much, right? So it's a 0.6 times 20. Like 14, 16 ml, something like that, right? So again, it's a very small amount. If I put that onto a pressure bag, Well, that's going to go in the blink of an eye for that patient, and so I can fluid overload them very quickly. That's why for pediatrics, you really want to make sure you're putting things onto a pump and running that according to the guardrails they have there, the safety parameters they have set up. Because again, we've killed patients before, young patients, because I just let a liter of saline hang and just let it all run to the patient, and then fluid overloaded, can't oxygenate because now their lungs are full of fluid and they die. So be very careful with that. And peds, make sure you're using your pumps, make sure you're staying on the guardrails here. And again, are you the ones normally setting up the pumps and running them? No, the nurses will be, but it's important to know how these things are actually getting done, what the actual nitty-gritty is. And I implore you, while on rotations, take the opportunity to do what the nurses do in some cases, right? Look at how they set up pumps, look at how they handle medications and all these different things. So at least you have an idea like how things actually work out there in the real world. Don't just say, well, that's not my job. It's never a good thing you want to stay on rotation. It's a good way to get a very bad eval. Other things to consider, you could also just do the push-pull method. Sometimes we'll do that if we need to get fluids very quickly into a pediatric patient, where basically the nurse will plug up a syringe into the bag of saline, pull it out, and then punch that into the patient, right? You get 60 mLs at a time very quickly doing it that way. And then even faster than that, we have the level 1 infuser. You will see this in a lot of trauma centers or other ERs and places like that. You can infuse up to 500 mLs a minute. So you can get fluid in patients very, very quickly. It's good if you have like really massive trauma, they're losing a lot of blood, you need to get fluid in them fast. This is one way to do it. So just an example of the different ways and different rates that fluids can get in. Okay, what if you can't get an IV? What can you do instead? Now some of you may recognize these guys, or your best friends maybe, who can say. But what happens if you can't get an IV? What could I do instead in order to get fluids into a patient, right? So again, if you can't get an IV, what is the easiest way to get fluids into a patient? IO, right? If you have access to an easy IO, drill it into where? Tibia is most common, at least I've seen. The humerus can be used in some cases, the sternum, there's other places, but typically the tibia is more common one that I've seen there. Again, you're basically placing the fluids right there in the marrow. It's a very nice non-compressible vein essentially, right? So you can get fluids in very quickly. You can do the same rates as you would for an IV administration. What if I did not have access to an IO? Maybe I wanted to use something non-emergently, right? I want to give them some fluids, but I don't really need to get it in that fast. Well, that's where you have this process called hypodermoclysis. And in fact, anyone with animals who's taken their animals to the vet to get fluids, this is the same thing, right? How do you give fluids to a dog? Subcutaneously, right? So you do the same thing for people as well. Basically, we have a drug called Hylenex, which is hyaluronidase, that will go in and start to break down hyaluronic acid in the sub-Q connective tissue, and it will allow for expansion of that skin. Basically, we're kind of separating the skin off from the rest of the connective tissue and allowing for that fluid to go in there. You can give full fluid boluses into patients. Sometimes you'll do that between the shoulder blades. Then I have a nice little camel humpback for a little bit, and then it'll get absorbed to the systemic circulation, and then you're good to go, right? So again, that could be one way to do it. Here's some people who are using some extreme body modifications. They're actually using Hylenex in order to give themselves these nice little donut sort of things. Again, different strokes for different folks. Mine didn't look that good. I don't know. Just I guess maybe I didn't use enough Hylenex or something. But anyway, but just know there's different ways to get fluids in. You're not always restricted to just using IV access. Okay, as I mentioned with maintenance fluids here, you're going to find that this is just to try to maintain fluid balance. You're not going to necessarily get them repleted very quickly by doing this. And again, the 4-2-1 rule is always going to be very handy. I recommend using that even for adult patients. It can still be applied there, right? As I mentioned, usually for adult patients, 30 to 40 mLs per kilo per day, roughly 2 to 3 liters. That's why 125 is pretty standard, because that equates to 3 liters a day essentially. Okay. Now, sometimes you'll see on orders they may say half maintenance, 2 times maintenance. Usually you're using 125 mLs an hour as your baseline. However, it's always better to be specific. If you can, just say, hey, it's 125 mLs an hour, right? Or 250 mLs an hour, whatever the case may be, okay? When you're actually entering in orders on the electronic medical record, you'll find you have to actually put in specific numbers anyway, so. Okay. As I mentioned, what fluids to use for maintenance, typically anywhere between 0.45 to 0.9%, so half normal to normal saline's appropriate here. Again, you're more likely to have an iatrogenic hyponatremia and trigger also ADH release by giving hypotonic saline here. So again, normally default to NS if you can. Typically dextrose 5%. This will help to provide some extra calories here. Now again, if I'm saying dextrose 5%, let's say that means 5 grams per deciliter, or roughly 50 grams in a whole liter of dextrose, and I infuse that to a patient, how many calories is that? So 50 grams of carbohydrates turns into 50 times 4, it's 200, right? So again, a liter of D5 in S contains about 200 calories you can give to a patient. And again, if they're getting 3 liters a day of that, It's getting 600 calories. Now, is that going to meet anyone's general needs for intake? I should probably be on a 600 calorie a day diet, but regardless, generally no, right? But again, the idea is to try to keep them from getting to kind of a full-on catabolic state. Just give them enough to kind of keep them going, right? And again, this is generally for more short-term sort of courses there, right? So again, if they're going in for appendicitis and they're in PO for a day or two, that's enough, right? Patients can generally go a decent amount of time without food, but they always need to have fluids. Okay. As I mentioned, potassium, usually 20 to 40 milliequivalents per liter, is generally added. KCl is the most common, but you may see K-acetate, K-phos, depending on what the patient needs. Avoid it if they're already hyperkalemic. Anyone remember the mnemonic for hyperkalemia? C, a big K drop. I had a student on rotations, actually came back and said, you know what, my preceptor pent me on the first day in the ER. How do you treat hyperkalemia? And he had the same mnemonic I use. So again, good stuff to remember, right? I just don't teach you stuff just for fun's sake. It's not fun. It's serious stuff, okay? Anyway, but yeah, so remember, C, a big K drop. What is that? What does that mean? C is calcium, stabilizes myocardium. A, albuterol. B, bicarb. Remember, alkalemia, right? Getting the patient more alkalotic drives potassium into the cells. It's the IG. Insulin, glucose. K. Okay. And then dialysis, right? Drop is the dialysis, right? It's the ultimate way to get rid of potassium. Most of the other things are getting potassium shifted into the cells. K-Xylate will get it off, but again, it's not quick, right? So good to remember that. Anyway, and then again, LR, typically not used for maintenance fluids because again, you will lead to an alkalemia because you do get a lot of that lactate being converted to bicarb. So it's less frequently used, more so seen like in the bolus sort of setting there. Anyways, how do you monitor these patients here? Obviously, physical exams are going to be important. You should see them start to appear clinically more hydrated, right? Skin turgors are going to get a little better, cap refills better, all these different things. Mucous membrane should be moist, etc. Obviously, heart rate should come back down, blood pressure should come back up, and also you're going to be measuring serum chemistries. Remember, your BMP is just at Chem 7s. You're only going to get a couple of things there. If you want more, either get a CMP or order the labs individually, magnesium, phos, calcium, whatever you need, okay? And then urine output. So in terms of measuring output, this is oftentimes better than using serum creatinine to get a creatinine clearance. So why is urine output better? Well, it's a faster measurement, right? If I stop making urine right now, you're going to notice it immediately because I'm stopping urine output. Versus creatinine has a half-life just like anything else. It takes time for that to build up. Remember, if you look back on those graphs and the renal stuff we covered in Pharm, you're going to see that it can be 2 or 3 days before creatinine really kind of adjusts based off of a kidney insult. So urine output responds much more quickly. Typically for an adult, between 0.5 and 1 ml per kilo per hour is considered to be sufficient. Usually pediatric patients are going to be an ml per kilo per hour or more. And again, you'll see some like neonatal patients will be 4 to 6 mLs per kilo per hour that make a lot of urine based on their weight, and that's totally normal for them. Okay. As I said, most people tend to stay on IV fluids much longer than necessary. When can you take patients off IV fluids? Yeah, when they have good PO intake, right? So again, if you have someone who's on a full diet and they're still on IV fluids, doesn't make a lot of sense, right? So get them off the IV, you decrease the infection risk, get them that much closer to getting discharged, right? And again, typically you're going to see, especially like when you're writing like surgery notes and whatnot, you'll say, hey, start the patient on maintenance fluids, advanced diet as tolerated. Once you see that patient start to advance, they're starting to get good fluid intake, PO, then you can go ahead and take them off the IVs, and then again, they're that much closer to being discharged there. Okay, so again, as we talked about the case here, we talked about how much you should be getting, the maintenance amounts, all that good stuff. So that's been covered. Other uses for fluids that you may see used occasionally out there. One cool thing you can do is actually mix and match fluids together to get different concentrations of things. So this is something you may see for patients with DKA, otherwise known as. Right. So again, this would be for like your type 1 patients who maybe get ill and they come into the ER and their sugars are 400 or 500 and their pH is 6.9. What you're going to see there is that we'll actually use a combination of 2 different bags to try and get their sugars down at a reasonable rate, right? Because again, if I have a patient who has been in DKA, say for the past 3 or 4 days, and I get their sugars down immediately, what can happen? Well, one thing that can happen is when I drop the sugar in the blood down very quickly, remember the brain's had time to equilibrate over 3 or 4 days. Now all of a sudden the brain's very hypertonic compared to the rest of the body. All that fluid is going to go shuttling up into the brain, cause cerebral edema. I've seen one DKA patient with such bad cerebral edema, they actually had to have partial craniotomy to relieve some of the pressure there. So again, it can be very, very severe. But again, we want to make sure we're dropping their sugars down not too quickly, but still, at a decent pace there. So you give them insulin, but you're also going to be giving them D10. And it seems kind of oxymoronic though, right? You're like, I'm giving them insulin, why am I giving them dextrose? You have to, because you don't want to make them drop too quickly. Anyway, what you can do though is have a bag of D10 with 20 of K-phos and 20 of KCl. Why am I giving so much potassium to these patients? No, well, I'm giving a lot of replacement potassium here, right? So why are DKA patients usually hypokalemia? Okay, so here's the thing. So I'm trying to think of a good way to get to it. So in general, as we mentioned, giving bicarb drives potassium into cells, right? So conversely to that, acidosis causes potassium to come where? Out of the cells, right? So when they go out of the cells, and typically when you're having DKA, what's the urine output like for those patients? Pretty good, right? So they're actually diuresing quite a bit. Remember the 3 cardinal signs of diabetes? Polyphagia, polydipsia, polyuria, all the extra sugar, all the extra osmolarity is drawing the water out, right? So you're getting a lot of urine flow. So they're losing a lot of potassium. So even though their potassium may look normal because the acidosis, that pH is 6.9 is keeping their potassium at, say, a 3.5, overall their entire body's depleted of it, which is why we have to replace that. And also phosphate and other things like that. So that's why we're giving a total of 40 milliequivalents per liter of potassium, because we want to make sure that we're getting repleted with that. And again, as the pH comes back up, you'll see all that potassium shuttle back into the cell, and all of a sudden they're like at 2. So that's why we're replacing that. Make sense? Okay, so anyway, so you can actually use a 2-bag method here. We're going to give D10NS with 20 of K-phos and KCl, and then we have another bag with NS, just plain NS with no sugar, with 20 of K-phos and 20 KCl. And so when you run the 2 in together, what does that make? Does it make double NS? Well, no, by running together both of those together in at the same rate, now you have D5 NS with 40 total potassium. And you can actually shift how much you're giving of each one to make sure that the sugars are coming down at a nice rate, but you're still giving them lots of fluid because they're generally fluid depleted. You're giving them the potassium they need, and that way you can get everything kind of corrected there. Now, if they're really acidotic, you can even give them K-acetate as an alternative. That helps to get the bicarb levels back up and helps to replace that. So again, little interesting things you can do with fluids to try to help your patients along, depending on what the disease state is, what the pathology is, right? As I mentioned, with acidosis, you can use D5 with 150 milliequivalents of sodium bicarb. That is isotonic, just like normal saline would be for those patients there. Because again, the dextrose doesn't really provide a lot of osmolality there. As an alternative, you could always use sodium acetate. In fact, we've had to do that on severe shortage before. Remember, 3% sodium chloride, very dangerous, but it's good to help draw fluid off of different compartments. So for instance, the extracellular space, you can draw that off if you have cerebral edema happening there, or it can be used to correct hyponatremia. And as I mentioned, albumin is good for increasing oncotic pressure. 5% dextrose, again, used as fluid boluses, typically more for volume support. 25% dextrose is going to be used more for oncotic pressure support, right? To help to keep the volume that's in the intravascular space rather than letting it just kind of leak it out. Okay. Okay, so let's say we have a patient here who, and again, I know I'm running out of time, but let's say we have a 1-year-old patient here who's 12 kilograms, presenting to the ER after suffering an anaphylactic reaction secondary to a peanut exposure. A rogue peanut came in and caused anaphylaxis in this patient. So first off, what kind of meds do you want to give this patient here? Heart rate of 160, BP 73/42, respiratory rate of 40. When he can't breathe. Epi, yeah, you probably want to give epi to that patient first, right? Anyone know how much you give? Think about EpiPen juniors is usually 0.15 milligrams epinephrine. EpiPen for adults usually 0.3. You'll learn this when you get into talking about ACLS in a little bit, so just keep that in mind. This patient probably get like 0.15 of epinephrine. You don't have to know that for this class specifically, but that's how much they would get. What else would you want to give them? Benadryl would be good. Good. So you probably give them 1 per kilo of Benadryl, so you get 12 milligrams of Benadryl IV. What else? Steroids typically, right? So you probably hit them with, say, 1 to 2 per kilo of methylprednisolone IV, so probably 12 to 24 milligrams of that. All right, now you want to give them fluids, okay? Who's my next volunteer going to be? Anyone? I will call it random. Random meaning who is matching my gaze. All right, David, thank you so much for volunteering. Sacrificial lamb here. Please stand up, gentle lamb. Okay, so to start off with a fluid bolus, what would you want to give this young child? He's hypotensive, even after the epi we gave him. So what kind of fluid do you want to give?
Would we stick to the 20 mLs per kg here?
Yep, that would be our dose. What fluid do you want to use? Again, this is easy stuff, right? Normal saline, right? Normal saline is normal. So let's start with that, right? So NS, how much do you want to give them? Now, if you just write 20 mLs per kilo on your order, so you're going to get a phone call about that, right? You want to give them an actual dose.
240 mLs?
240 mLs, how'd you get that?
20 times 12.
Fantastic. You can do math too on the spot. I can't do that even, right? 240 mLs, good. So NS. Good, so we have a route, so it's going to be IV, bolus. Fantastic, right? So you can start with that, right? And then in this case here, you can even say how fast you want to give that to this patient here, right? So again, when you just put bolus, it's typically as fast as you can get it in, especially for a patient who's really severely sick like this, you'd want to get it in as fast as you can. If you have time, if you're just, say, they're coming in with gastroenteritis, 30 minutes, an hour is probably okay for those patients as well, right? You don't have to bust out the level 1 infuser for them coming in for a little bit of vomiting, okay? Now, let's say, okay, we give them that bolus, got them topped off, blood pressure is looking good, heart rate's coming down, the epi's kicked in, feel a little bit better. What can we do for maintenance fluids? Say we want to admit this patient for observation overnight.
4-2-1 rule.
Okay, we use the 4-2-1 rules. First off, what fluids do we want to use?
NS or D5.
Good, so actually you write in both cases, right? D5 and S. Because you want to give them some sugar, especially little kids, like they need to have some energy source, right? They're going to be kept in PO. Adults, you can get away with not giving them as much sugar. Generally, they have more kind of stores they can rely on. Little kids, you can't do that, right? You have to give them some kind of carbohydrates at least. So in this case here, we use D5 and S. Why not half an S? There's no real clinical benefit to doing so. Again, I could just use NS and I'm less likely to cause a hyponatremia. That's really the biggest thing there. And so we went to the 4-2-1 rule. So that means we got 4 mLs per kilo for the first 10, so that's 40, plus 2 mLs per kilo for the next 10, and then he only has 2 kilograms to give there, so 44 mLs an hour would be good. Now again, if you just write 44 mLs an hour, do you have to write continuous? Not necessarily, right? So again, either way would be fine, but if you wanted to shorten it up, you don't have to write that. It's inferred. If you write per hour, that it means just continuously, unless you put some kind of stop parameter on there. And then what's our route? IV, right? So you always want to make sure you keep the routes on there to keep it straight. Okay. Very good. Any questions on that? Again, fluids don't have to be that hard. You just want to make sure that you're considering, okay, well, what kind of physiologic state is the patient in? Can they handle this much fluid? Can they not? Now, if this patient was still seeming to be somewhat volume depleted, you could run higher than maintenance if you wanted to. So if I want to do like 2 times maintenance, that might be reasonable for a few hours and then back it off to normal maintenance rates. It just depends on the patient. Yes, sir.
Earlier for the adult, we rounded up significantly from 1,600 to 2 liters.
Yep.
We round up in feet, let's say from 240 to 250, since the bag is 250.
Yeah, and actually that's kind of a bit of consternation I have in the hospital, especially with EMRs, right? So for instance, when you're in the ER, oftentimes you don't want to necessarily wait for someone to verify all this order, especially like basic stuff, right? So for instance, a basic order of Tylenol. It's really hard to kill someone with Tylenol with a single dose. Versus, fluids like a general fluid bolus, really hard to really hurt someone with that, especially a little kid. And so our things will default to very specific doses. So even our system, and I can't really modify because it's going to auto verify, it'll come across as 256 mLs, and I can't change it just to 250 bag. It'll dispense a 500. But practically, that's a very good point. If you were writing for 240, yes, that is technically the absolute correct dose to give. If you want to give 250, that's probably reasonable. Now, would I bump that up to 500? No, it's too much for a pediatric patient, right? So generally, if you're within 10% or so, that's pretty good, right? And again, the older the patient, up to a point, right? You don't want to give like a 90-year-old, you want to round up by 500 mLs or something. But for a normal healthy adult, the rounding it can be pretty generous from that standpoint. But very good point there. 250 would be totally appropriate there. Any other questions on that? Very good. So there's some other cases here you can kind of work through. I believe I have some comments down in the bottom that we can talk about. I don't really have time to cover all this today, unfortunately. Our time is so short, but sweet, I think. Because again, we had a lot of dextrose-containing fluids we're talking about today. So any questions I can answer beforehand. Again, work through these. You'll see there's some comments at the bottom. If you have any questions, let me know. There's a few dose calculations for pediatric patients towards the end there as well. You can go over anything else that I can answer any burning questions you've had about fluids, any fluids you've had, fluids you would like to receive, and maybe another dose of coffee. Yes, ma'am. On your version? Oh, yeah, the student version. I will post this version, and you'll have some answers down there, some comments. How about that? That'll work for you guys. Again, in general, you can always give more fluids. You want to be like a magician, right? You don't want to start the show with a showstopper. You don't want to solve the assistant in half right out the bat. But by giving, you want to give a little bit more, right? Start off with the card trick, and then eventually work your way up there. But, if you have a patient coming in and they're hemorrhaging massive amounts of blood, and you say, well, let's just start with 500 mLs, the patient's going to be dead by the time you actually get them fluid repleted, right? So, again, take the clinical situation in mind. Okay? Any other questions I can answer for you? All right, great. I'll meet you guys here next week. We'll have our Pharm topics. That'll be the first time I'm doing that one, so that'll be all brand new. So get ready for that. And I'll see you guys next time.